moments in every person's lifetime when every decision counts and every choice has consequences. In healthcare, those moments can mean the difference between life and death. At St George's, there's a unit dedicated to helping teams work together to make the right choices every time. The Simulation Centre at St George's carries out simulations in 3 areas: through their skills laboratory, in mobile simulations taken into the actual hospital environment, and in their high-fidelity simulation units, which provide an environment identical to real life.
No, we're not. Listen to the doctors here. Do you mind if we just have a look at you?
Built in 2011, the Simulation Centre is home to a top-of-the-range clinical skills training laboratory.
We have the 3-day basic surgical skills, which is a requirement from the Royal College of Surgeons. So that's a 3-day course that's teaching them the basics of suturing, tissue handling, manipulation, and using different suturing techniques like anastomosis versus simple skin suturing, tendon repair, vascular work, and lastly is minimally invasive surgery.
In the Skills Lab, trainees can use box trainers and other specialist training equipment, along with identical surgical tools to those found in operating theatres. The lab is used to help train students, staff, and already skilled surgeons.
At the high-end level, where we have some brilliant champions in St George's who have been perhaps on training courses in Europe, and they are keeping their skills refreshed, so they come up here once a week and just keep their laparoscopic dexterity skills in place.
Mobile simulation allows the team to take their simulation and filming equipment into the actual clinical environment.
One of the problems we often have with intensive care patients is the transfer of patients from an intensive care unit to somewhere else. So what we do is we try and recreate those events with the simulator, and then my role as the facilitator of this is to take the team back afterwards, look through the videos, look at what we can do better, and look at some of the things that we do well as well.
They're using the same equipment they'd use on a real patient, they have the same policies that they have to adhere to, and therefore the human behaviour is more likely to be what would happen on a day-to-day basis. The unit is primarily made up of 2 clinical simulation laboratories which represent a normal clinical environment at St George's Hospital. The same fascia, oxygen, alarms and monitoring.
Sorry, go ahead.
I usually just get a bit of indigestion. I take some relief for
Okay.
Okay,
so you've had a few of the sprays, is that right?
many tablets for my indigestion.
We now have 2 high-fidelity simulation suites to run 2 clinical environments at once with 2 separate medical and nursing teams who are required to collaborate, communicate across and share resources, etc. So we're able to do that with our new design and the way that it's been designed, that our control room runs across both of these clinical laboratories, allowing us to keep an eye on the learning objectives individually as well as the team learning objectives.
In the control room, Nick and his colleagues can control every element of a scenario and observe team reactions to an emergency. Even those not directly involved can watch and learn from the experience.
It's blood pressure. Blood pressure's gone. Oh, thanks for What happened?
Oh no.
Oh,
Okay.
has it got a pulse?
No.
Have you checked a pulse?
Crash call to restart. We're going to stop there, well done.
Well done.
A simulation day would consist of a welcome and introduction and meeting the mannequin, and this is probably one of the most important aspects of it because it is, after all, a pink and plastic mannequin. But it's very important that we introduce the simulator as just a simulator, and they still need to seek information from their patient through communication, through touching, as well as using the medical equipment.
This is a METI HPS mannequin. With both the high fidelity mannequins that we have, we do an introduction via the ABCD system. So we'll start with A, the airway. It has a fully functioning airway. The vocal cords can occlude, tongue can swell, and also it can go into laryngospasm. So if you were heavy-handed with a laryngoscope, if you were putting it down, it would sense that you were putting the laryngoscope down the throat and go into laryngospasm. B, breathing. We have independent air entry into both its lungs. It can have a variety of breath sounds. It can have a wheezing, a riles, a crackles. It has independent air entry, so we can have a one-sided silent chest. So if he were to have a pneumothorax, that's easily identifiable by the chest excursion. Staying with breathing, it's a very clever piece of software that can actually tell what delivery device and oxygen therapy you're delivering. So that means that if you were using nasal specs, that's what he would react to. If you put on a Hudson mask with a reservoir bag, so that's high flow, high concentration, that's what he'll react to. If you don't put it on and plug it in, it will continue to desaturate and he won't react. So it's very important that you do what you would normally do in the clinical environment. To C, he's got a carotid, brachial, radial, femoral and popliteal pulse. Anatomically, they're incorrect, as with most mannequins on the market today. So therefore, it's important that when you meet the mannequin that you're comfortable where the position of the different pulses are. With C also is the delivery of fluids. If you're giving fluids today, you're not going to be required to cannulate the patient. We set the cannulas up in situ, dependent upon the scenario, and then give fluids. It's very important that you do what you would normally do in the clinical environment. So on this mannequin, you can spike a bag of fluid, hang the bag of fluid, and put the bag of fluid through at the rate you want. And he will react to what you do and what you don't do. So after giving your fluids, if you don't see the physiological effect that you'd expect, then you know that there's a red flag, that there's something going on. So it's important to give fluids. So with D, disability, you can do blood tests on this patient. However, it's something that normally the nursing staff will do for you today. The same with arterial blood gases. You can take them, but the nursing staff will take them, they'll go away and bring you the results, and it's all in real time. You can also do a neuro assessment because the patient's eyes will constrict and dilate to light. So you can shine the light in and you'll see a constriction. So if you don't see that, you can check with your nursing staff if you're unsure what you're seeing, but you can also have a blown or a constricted pinpoint pupil. The important thing to remember is treat the mannequin as a real patient. Do the things that you would normally do. It's better to do them and be told that you can't do what you want to do than rather say, oh, I'll leave it because it's a mannequin, I won't ask if I can do that. So treat them as a real patient, you'll get the most out of the day.
Each simulation is reviewed and analysed afterwards to facilitate learning.
It's quite honest feedback at the end. That's something that you don't get in a hospital scenario. And there's some slight reassurance that I might actually be able to cope with help and in team with an acute situation.
The feedback we get from our learners after courses is generally quite positive. I think most people have found that it's actually a really useful learning tool, and that's what it is. It's a learning tool. It's not an assessment tool, and I think that's the major battle we have is convincing people that we're not here to test them, that we're here to stretch them and to challenge them and to get them to think about their own practice and to build on that. But it's a learning environment, and we're very much about formative learning for their own information rather than a testing summative environment.
Simulation's quite a technical business, but actually for it to work, it needs to disappear in terms of a technology. It needs to be as close to the workplace as possible, because what we do is we're helping people learn together as real clinical teams. It's often seen as a rehearsal. It's also often seen as something that gets in the way of knowing things, real things about how to look after patients. I don't think it gets in the way, I think it helps. And I think its main purpose is to help people think about how they practice.
I think simulation's more about team development and team structure, and looking at those non-technical aspects of team interaction. We need to be able to communicate effectively, which is always difficult, especially when you're stressed, when patients are sick. Sometimes we don't communicate as effectively as we would want to. But also having the confidence to speak up and verbalise what we're thinking, and to have what we call situational awareness about it.
One of the things that for me is really important about simulation is it's an opportunity for people to talk, discuss professional practice, and to receive feedback from people who've been observing them in this non-threatening environment. So I see simulation as fundamentally a social practice.
Over the years, I think we've seen the use of simulation, and certainly St George's has been one of the leading trusts on the use of simulation and response to human factors. This new bill wouldn't have happened without the Chief Exec and the Trust Board being behind patient safety and education in a big way at St George's. And I only hope that this continues and that we see more of it in the future.
That's what we can see simulation offering, giving people the tools to work out some of their own solutions for clinical problems that they see or for problems of delivering clinical care safely.